Good morning, everyone. Thanks so much for attending. We're really excited to hear this presentation from Transplant ID, and I'll let Sasan introduce their speaker. Thank you.
Of course. Good morning, everyone. Dr. Rbab Taha is a Transplant ID fellow. She's originally from Syria and completed her internal medicine residency and then infectious diseases fellowship at Saudi Arabia, King of Fahd Hospital. And then she actually right away started her Transplant ID fellowship after her ID fellowship training in Saudi. She actually accepted this presentation relatively with a short notice. Another fellow was supposed to present today. Because of family emergency, she wasn't able to do her presentation. So Rbab kindly accepted to do the presentation. Thank you, Rbab. Please go ahead and tell us about Candida in SOTs.
Yeah, so should I start? I'll get started now. So no conflict of interest. Actually, I picked this topic, the Candida in solid organ transplant, because candidiasis is a major cause of mortality and morbidity after solid organ transplant, particularly in liver transplantation. And it is the third most common nosocomial infection in solid organ transplant. Early diagnosis and initiation of treatment are necessary to reduce mortality. So I will start with my main objective is to review the risk factors for invasive candidiasis in solid organ recipients, to review the indications of antifungal prophylaxis targeting Candida species in solid organ transplant recipients, to review the indications of antifungal treatment following isolation of Candida species from different specimens. I'll start with the case, then we'll discuss after the case. 52-year-old male patient underwent right lobe liver transplant from a living donor, secondary to NASH-related liver cirrhosis. MELD score was 23, received 25 units of RBCs and platelet transfusion. His liver transplant complicated with biliary leakage post-operatively, and his creatinine was 150. So the question now, would you start antifungal prophylaxis in this case or not? To answer this question, I will go through the epidemiology and risk factors, then I will go back to this case. So Candida is the most common species through the invasive, the most common type of invasive fungal infection in solid organ transplantation, except in the lung, where Aspergillus is more prevalent. And this study done across all over Ontario by Husseini et al. And it showed that invasive candidiasis, it is done on 9,326 solid organ transplant recipients. And it showed that 39% of the cases is due to invasive candidiasis. The incidence rate of candidiasis is highest in liver transplantation, as it accounts 90% of all invasive fungal infection in the liver, followed by small bowel transplantation, and renal transplant are the least, have the least incidence of invasive fungal infection. However, candidiasis accounts 75% of all cases in renal transplant. Usually the timing of invasive fungal infection in the first 3 months after the transplantation. However, it can happen anytime or on later stage after the transplantation, but the highest incidence is in the first 3 months. The most common species from the Candida is the Candida albicans, similar to controls. However, the epidemiology has changed markedly over recent years, and Candida glabrata accounts now almost 30% of all cases through solid organ transplantation, and it accounts 51% of candidiuria. So kidney transplant is a independent risk factor for non-Candida albicans. Why it's important to know this epidemiology? Because we need to know which antibiotic we should give in this situation. For example, this study done recently also in 2020 across Ontario on immunocompetent and immunocompromised population. And it showed that Candida glabrata now, the resistance to fluconazole in Candida glabrata up to 12%. However, this varies between countries based on the epidemiological data, and it reaches in some reports to 16%. The other thing why we need to know the species, because the species is also associated, the mortality varies between species. So if we compare the mortality rate in controls and patient who has invasive candidiasis, so the mortality rate is 25 fold higher in patient with invasive candidiasis, and it is 22% for Candida albicans in comparison with 58% for Candida glabrata. So Candida glabrata or non-Candida albicans is associated with higher mortality rates. So, and this necessitates the question of what are risk factors for non-albican species? Actually, there is a lot of studies done in this regard, especially in the liver transplantation. And in univariate analysis, it showed that methylprednisone is an independent risk factor for non-Candida albicans. And we hypothesize that it is a marker of rejection. Kidney also in a univariate analysis also associated with increased risk of Candida glabrata. Triazole therapy or previous azole therapy also associated with non-Candida albicans. However, in a univariate, in a multivariate analysis, Black people, female, and pancreatitis is also associated with higher risk of invasive candidiasis. We said about the previous therapy, this a prospective study done in France. It is an epidemiological study. It showed that previous azole therapy increased the risk of non-Candida albicans. So it's very important to know when we want to start the antifungal treatment or prophylaxis, it's very important to know which antifungal, what are the risk factors, what we are targeting. The diagnosis, usually we diagnose cases based on the recent published IDSA guidelines in 2020, which is the update of consensus definition of European Organization for Research and the Treatment of Cancer. And we depend also on International Society for Heart and Lung Transplantation to diagnose invasive fungal infection in lung and heart transplant. Why is this important, the criteria? Because sometimes it's not obvious and not easy to diagnose Candida, because we know the yield of the sensitivity of Candida culture is from 50 to 70%. So we have a false negative result in 30% of the population. So now I will start with, I will back to my question. I will start with the part of prophylaxis. I will try to answer this question in my next coming slides. Which solid organ transplant groups should receive prophylaxis? Should we give the targeted prophylaxis or universal prophylaxis? Who is at high risk? Who is at high risk? Which medication we should give? Is it fluconazole, echinocandin, or ambisome? And the duration of prophylaxis. I will start with the risk factors. As we said, the liver transplant and small bowel transplantation are the highest risk of invasive candidiasis, as it accounts for more than 90% of invasive fungal infection in liver transplant. So we can divide the risk factors for during the surgery, risk factors during surgery, pre-operative and post-operative. So during the surgery, the risk factors is technical complexity of the surgery, prolonged operation more than 11 hours, multiple blood transfusion more than 40 units. And usually we get asked a lot of the blood transfusion. And there was previous trials comparing the blood transfusion. Is it if it is less than 40 and more than 40. So if it is less than 40 and 1 risk factors, there was no significant increase in invasive fungal infection. The other risk factors is the ROX-Y biliary anastomosis and pre-transplantation. The pre-operation risk factors are antibiotic prophylaxis for spontaneous bacterial peritonitis, encephalopathy and creatinine level more than 2. Post-operative is post-transplantation dialysis, encephalopathy, and post-operative bacterial infection. So now I mentioned these risk factors. So when we should start the antifungal prophylaxis, actually, if we have more than 2 risk factors of the mentioned in the previous slide, we should start antifungal prophylaxis based on studies, multiple studies, but the most important done by Hussein et al. And Singha et al. Because if there is more than 2 risk factors, the risk of invasive fungal infection will jump from 5 to 10 up to 67%. And if we have 3 risk factors, so the risk of invasive fungal infection will be almost 100%. What about the small bowel transplantation? We know that small bowel transplantation is also associated with high risk of invasive fungal infection because maybe of the contamination in the during the operation. So based on last American Society guidelines that published in 2019, we should go for a universal prophylaxis with all small bowel transplant, and most probably because of paucity of evidence in this regard. What about the pancreas? The pancreas risk factors are enteric drainage, vascular thrombosis, and post-perfusion pancreatitis is significantly associated with high risk of invasive fungal infection. So if we have only 1 risk factor in those, we need to give prophylaxis. So now back to the case. I will highlight just the risk factors. So the patient received 25 units. It is not a risk factor, but we should consider it also still if there's another risk factors. The other one is biliary leakage postoperatively, although it was not mentioned in the previous studies. However, now the new studies highlighting and they proposing that biliary leakage is independent risk factors for subsequent invasive fungal infection. Creatinine usually should be more than 2 to start antifungal prophylaxis. So this patient, however, he was not started on antifungal prophylaxis. On day 55, he came with sepsis, symptoms of fever, tachycardia, hypotension, leukocytosis. He was started on empirical antibiotic, imatinib, teicoplanin, and echinocandin. Multiple CT thorax and CT abdomen done, it showed multiple liver abscesses despite the negative blood culture. As we say that the yield of blood culture is not always positive, it's not high enough. So patient started empirically on antibiotic, but after 2 days after repeating the blood culture, it came back positive with Candida albicans. Patient started on proper medication, echinocandin. However, on the 3rd day, patient came with history of, he was assessed by ophthalmology for visual acuity, and he was found to have retinitis. So it's very important to involve infectious disease in some situation because, for example, echinocandin won't penetrate this area and won't be efficient for retinitis. So now we answered that we need to give prophylaxis in certain groups, but why? What is the justification? There is a lot of studies done in this regards, and I will highlight the most important one. Or like the conclusion, there was agreement between those studies. This is a meta-analysis done on 6 randomized controlled trial. And it showed that giving the prophylaxis for high-risk population, it will associate with less total episodes of superficial and invasive fungal infection, less mortality attributable to fungal infection, and did not affect the overall mortality or the need for empirical antifungal treatment. So we should give prophylaxis, but should we give a universal prophylaxis or we should give targeted prophylaxis? And is there any difference in mortality or invasive fungal infection? This study is also a retrospective study done on on liver transplant patient, and it showed that no, as you can see here, the image on the upright corner, there was no significant difference in survival when we give a targeted based on the risk factors or universal, and there was no significant increase in invasive fungal infection in the targeted group. So the conclusion, we prefer the targeted group here. As the targeted group, if we give the targeted antifungal prophylaxis, it will decrease the toxicities, it will decrease the Candida albicans, it will decrease the interactions, and definitely it will decrease cost, and it won't increase the risk of invasive fungal infection. Now, we say that we need to give prophylaxis in high-risk patient. We need to give a targeted prophylaxis. Now, which medication is it? Azoles, echinocandin, or ambisome? So this study is a randomized controlled trial done. It is of micafungin compared with the controls. The controls received ambisome and fluconazole. The conclusion of this study that micafungin proved to be at least as effective as the standard of care, which is the ambisome and fluconazole, and liver function tests were similar in both groups. In addition, the creatinine clearance is better in the micafungin group. Why? Because we should generally avoid the ambisome in solid organ transplant if it is not needed, because all the study done on the old or conventional ambisome, liposomal amphotericin, and it showed that transplant recipients has increased in creatinine by 36%, and 18% of those population require dialysis. So even with the new liposomal amphotericin, still the kidney injury is significant in ambisome. What about, now we left with the fluconazole or anidolafungin, which one we should choose? And usually, we shouldn't give haphazard, because as we say, even caspofungin or inappropriate antifungal prophylaxis might increase the risk of non-Candida albicans. So it is a randomized controlled trial done on 200 liver transplant recipients, compare fluconazole with anidolafungin, and it showed that no significant difference in overall incidence of invasive fungal infection, but there was significant degrees in Aspergillus colonization in anidolafungin group. So now the conclusion, I said this conclusion. The conclusion of the part of prophylaxis in liver and in other solid organ transplantation, that antifungal prophylaxis should be targeted at high-risk patients and shouldn't be universal. Fluconazole is the preferred agent usually in liver transplant recipients and in small bowel and the pancreas. However, we should give the fluconazole if patient is stable, not neutropenic, and he had never received azole exposure therapy before. When we should give echinocandin should be considered particularly in the early postoperative period in recipients of abdominal organ who received azole exposure. What about the duration? Actually, the duration, there is no definitive studies about duration. All previous studies done the duration was between 4 to 10, and expert opinion is 4 weeks is enough, because we don't want to increase the risk of non-Candida albicans. Now I will talk about the prophylaxis also, or the preemptive therapy in the lung and kidney with the treatment. I will start with this case, 42-year-old woman. She had chronic obstructive pulmonary disease, recurrent infection, empyema, needed chest tube before the transplant, bilateral lung transplantation done. She had an uncomplicated immediate postoperative course. 3 days later, she was readmitted with progressive dyspnea exertion. Multiple sputum cultures grew Candida albicans. So now the question, If anyone from the lung team would like to participate, it would be my pleasure. So would you start fluconazole? Would you treat if there is a decline in respiratory function? Would you do BAL, bronchoalveolar lavage, or would you ignore as it won't affect the mortality? Actually, we did the bronchoalveolar lavage because of the recurrent. We recommended, or the patients already, they are going for a surveillance bronchoscopy. However, because of the recurrent isolation of the Candida and there was no other isolated organism, we did the BL, and the BL showed anastomotic dehiscence or kind of necrosis or infection, which we started fluconazole and 1 weekly nebulized ambisome, liposomal amphotericin B, and follow-up bronchoscopy showed resolution of the initial findings. Now, I will discuss later when we should treat and when we shouldn't, but the second case also in a lung transplant, it is a 70-year-old gentleman with a double lung transplant secondary to COPD done in 2019, CMVD negative, recipient negative. He went for ECMO after the lung transplant for 7 days. His lung transplant complicated with non-infected right-sided chest wall hematoma. Surveillance bronchoscopy Candida showed Candida albicans, which ignored because we usually don't always treat Candida albicans from BBL. August 20, the patient admitted as a case of Candida albicans. Osteomyelitis, debridement, and proper antifungal was done. But 6 months later, this is an actual case in our hospital. 6 months later, patient developed mediastinitis involving his ribs, incision and debridement of the right chest wall along with the resection of portion of the rib 5 and portion of rib 6 was done. Those cases necessitate the following question. Does isolating Candida from BAL increase the risk of invasive candidiasis? Does it increase mortality or rejection? Does it facilitate subsequent other infection? Actually, especially in this regard, we don't have a lot of trials, and there is a subsequent now undergoing the trial done by Dr. Hussein and Tina, our colleague. We are waiting for the result. So this study, it is done in 2018. It showed the impact of Candida colonization after lung transplantation. I won't go through details, but the most important thing that the result of this study is there was no significant difference in overall mortality in those patients who were colonized or who were not. However, the odds of graft dysfunction were 3 times higher in those colonized with the Candida transplant compared to those are not colonized, but it is not also definitive result. Subjects colonized with the Pseudomonas at the time of transplant were 71% more likely to have Candida isolated 6 months after the transplant. Surprisingly, the majority of Candida colonization was a donor-derived infection, indicating that reassessment of donor antimicrobial management might be warranted. And some other studies, as I said, there was only like retrospective case control studies. One of the prominent things that we really need to study that maybe Candida colonization will increase the risk of bacterial infection like Pseudomonas and some other, and Aspergillus. So it might be a point to be studied, and it might decrease the graft dysfunction, the subsequent infection, and the mortality. We don't know. This study also done about on patient with a lung transplant. It is an observational retrospective single center study on 176 patients. The Candida was colonized, like 17% of patients were colonized in a pre-transplantation period, and 67 were colonized in a post-transplantation period. As we can see here, the study showed there was no significant difference in the survival rate. And there was no significant difference in invasive fungal infection incidence. Now, I will go back to the previous cases. So to know when should we treat the candida, the isolation of candida from the bronchoalveolar lavage, and when should we ignore it, we need to know the risk factors. So ECMO is a significant risk factors for invasive candidiasis, or in general for infections. So this study is showing that Candida species is the most common infection following ECMO. And the longer the duration of hospitalization, or the longer the duration the patient is on ECMO, the higher incidence of invasive fungal infection. So this approach will show us when should we treat, when should we ignore, and when should we give a preemptive therapy. So if we have a Candida from bronchoalveolar lavage samples, we need to do the BL, like a frequent isolation from the BAL without any other evidence of any other fungal infection. We need to do the bronchoalveolar lavage. If there is any tracheal bronchitis, anastomotic dehiscence, empyema, or phangemia, we need to give treatment. We need to treat based on the sensitivity. If no, then we need to evaluate based on the risk factors. So should we give like preemptive therapy, or should we ignore this result? If we have any two, the suggested approach is, if we have two of the following, we need to give preemptive therapy. So if the patient is on ECMO, or if he had a pre-transplant chest tube, or immediate post-transplantation, re-explantation of the re-exploration of the thoracic cavity. If the donor or recipient pre-operative positive BL culture with a Candida species more than 10 to the power 6, then we need to treat or to give a preemptive therapy. If no, we need to ignore the Candida from the bronchoalveolar lavage. Which medication? It will be fluconazole, waiting for the sensitivity and the susceptibility. If positive galactomannan, then we need to give voriconazole, because we know this lung is an independent risk factor for aspergillus. So some of other centers, they are giving a universal prophylaxis with the voriconazole or with the anti-mold, antifungal. So at that time, we don't need to cover the Candida, definitely. The suggested duration is 4 weeks. And this study also, it is all the study done in 2012. It showed that it also compared the targeted prophylaxis versus the universal. And it showed that invasive candidiasis incidence declined markedly with the implementation of targeted prophylactic strategy. Now, finished from the part of the lung, I will come to the renal. I'll start with this case. 31-year-old woman with end-stage renal disease secondary to mesangiocapillary glomerulonephritis received a cadaveric renal transplant. She's on proper immunosuppression. Transplant function was satisfactory with a serum creatinine of 95. However, by day 10, she had become febrile with severe oropharyngeal thrush, and blood cultures grew Candida albicans. She was initiated on fluconazole with the apparent complete clinical response and negative blood cultures. During the treatments of the candidemia, the serum creatinine increased to 150 millimole per liter. Ultrasound, Doppler normal, but the transplant biopsy confirmed acute cellular rejection. Definitely, this was treated with intravenous methylprednisone. However, her subsequent condition remained stable with excellent allograft function, but 2 months post-transplant, she developed non-disabling intermittent claudication of the left lower limb and had creatinine of 150. Her Doppler at that time then also, they were suspecting the rejection, but it came back with a mycotic aneurysm and was confirmed with the angiogram. The patient underwent for transplant nephrectomy and excision of the aneurysm, where the saphenous vein patched to the external iliac artery. So mycotic aneurysm is one of the most important complications, although it's very rare, but it is like associated with a very bad prognosis. So there are like case reports about the mycotic aneurysms, and we should really suspecting mycotic aneurysm, especially if the patient had previous candidiuria or a positive candida culture from the donor. The conclusion of this study that external mycotic pseudoaneurysm are rare complications after kidney transplant. Post-transplantation mycotic pseudoaneurysm often led to loss of the graft. Early diagnosis and treatments can preserve the graft and lower limbs and lives. Now, the important part in renal transplant is the asymptomatic candidiuria. So when we should treat candidiuria. To answer this question, we need to know, does candidiuria affect the mortality? Does giving the prevention or the antibiotic or the antifungal will prevent further invasive fungal infection? So this study done on 1,738 patients, it showed the conclusion of this study done on renal transplant recipients. It showed that candidiuria is associated with reduced survival rates among persons who have undergone renal transplantation. However, treating the asymptomatic candidiuria in renal transplant recipients does not appear to result in improving outcome, but all of those studies done after the 2 months, while the patient was not on a stent. Candidiuria occurs in 11 to 20%, almost, the asymptomatic candidiuria in 11 to 20% of patients following the kidney transplant. And generally, we don't recommend giving to treat asymptomatic candidiuria except in certain situations where there is recurrent isolation, patient has like significant pyuria, then we need to treat asymptomatic pyuria, asymptomatic candidiuria. So, but if we have symptomatic candidiuria, which is cystitis, then we need to treat it like pyelonephritis. We need to give 14 days of fluconazole or ambisome, and we should avoid echinocandin in treating urinary tract infection, because candidiuria won't go to echinocandin, won't go to the brain, and it won't penetrate the kidney as well. Yeah, that in regards to kidney transplant. Now, generally for infective endocarditis, if we have any isolates from the blood, we need to involve infectious disease, because we need to rule out the involvement of the retina. We need to rule out infective endocarditis, because the drug of choice in infective endocarditis is ambisome. However, echinocandin can be given in high doses, but it's not studied well, but it can be given in high doses. What about meningitis? Meningitis in solid organ transplant, also very rare, but again, we shouldn't give echinocandin. And when we give echinocandin, we should know that there is interaction with echinocandin. Like we know all of us know that azoles have interactions, but echinocandins also has interactions. So micafungin will increase sirolimus level by 20%. Caspofungin has minimal interaction with calcinuria inhibitors, and anidolafungin has the best hepatic profile in comparison with micafungin and caspofungin, but this study is done in immunocompetent. We really don't know in solid organ transplant. Now, last part of my presentation is the donor-derived fungal infection in organ transplant recipients. So also I'll start with this case. A 50-year-old male patient went for a double lung transplant. Screening from the BL culture from donor was positive for Candida species. So should also we ignore this? Should we start, and why? We should definitely, or we don't know exactly based on studies, but based on the last American Society guidelines, we should treat. because there is some complications, although it is very rare, but these complications is associated with high mortality rates. For example, this is a case we saw it in the clinic with Dr. Humar. It is a case of possible donor-derived candida infection in lung transplant recipients, initially presented with empyema that was treated successfully, subsequently developed chronic meningitis. Diagnosis was delayed due to the low yield of CSF cultures and was confirmed with a fungal PCR. And empyema is associated, like Candida empyema is associated with higher rate of mortality. This case control study done on 455 patients, it showed that 60% of the empyema following the lung transplantation is secondary to invasive fungal infection. 90% of those cases is secondary to Candida. The 1-year survival of patients with a pleural space infection in this series was significantly lower. So now, based on the American Journal of Transplantation, when we should treat, if we isolate the Candida from the BL from a donor, antifungal therapy should be employed if donor bronchopulmonary secretions yield Candida until a repeated bronchoscopy is performed 1 week post-transplant to evaluate the anastomosis. What about the kidney and liver? Donor candidiuria doesn't contraindicate the acceptance of the organ. However, prophylactic antifungal should be given if there is a positive culture or if there is a history of intestinal perforation in the donor. So then we should give also a prophylactic antibiotics. And use of the organs from donor with untreated candidemia is completely contraindicated. Now, this for heart team, finally, for heart transplant team. So what about Candida auris? Because Candida auris is emerging recently in all over the world as a resistant organism. And sometimes in a part of in India and China, it can be resistant to echinocandin, ambisome, and to fluconazole, so there is no other drug. So what is our approach in if we run into a Candida auris? Actually, there is only one case series and some case reports about Candida auris in transplantation. And this case is in heart transplantation patients. So it is a 5 cases of colonization and 2 cases of candidemia. All of them were hospitalized in the ICU. Other had previously been treated with antibiotics for some bacterial infections with some bacterial infections and 1 antifungal. All of them had a central venous catheter and bladder catheter. The important thing that mortality rate was high, up to 80%. Like 80% of those patients who were colonized or who had candidemia, they died. So it's very important if we have a Candida auris, like there is also, in this study, they proposed an approach, but based on very limited population, that if patient is colonized or had any, like even candidiuria or asymptomatic candidiuria with Candida auris, then we need to do the blood culture and the blood PCR even to check that patient completely has no candidemia or Candida in the blood. Otherwise, we prefer not to take an organ from patient with a Candida auris. There is advantage a little bit in antifungal. There is some progress in the antifungal treatment, and this medication new is Rbab Rbab. Is a novel antifungal treatment. It has been studied in immunocompetent patients, but we don't have a lot of studies or we don't have any studies in solid organ transplant. But I think it is very promising medication because it is active against yeast, against mold. It is active even against PGP, and it has less side effects and less interaction with the calcinuria inhibitors. And it is fungicidal, so most probably it can be given as for the blood. And the most important thing that it can be given as oral. It is an oral tablet. So to sum up from the beginning, we need to give a targeted prophylaxis. We need to stratify based on this risk factors, especially in the liver. We need to give a universal prophylaxis in small bowel transplant. We need to give a prophylaxis in pancreas if we have one risk factors. In the lung, we need to stratify based on that approach if we should treat or we should go with a preemptive therapy. Candidiuria, usually we don't like asymptomatic candidiuria. We don't prefer to treat it except in certain individuals. And targeted prophylaxis is preferred definitely over the universal prophylaxis, but we need more studies in regard to colonization and invasive fungal infection, the duration of treatment. We need maybe inhaled liposomal amphotericin B might play a role in decolonization, but we don't know. We need more studies about asymptomatic candidiuria in the first 2 months. And we need to treat donor positive culture should be treated based on the previous slides that I mentioned. And more studies are needed in factors that predict the likelihood of transmission of Candida and the outcomes of Candida isolation from the donor. What is the outcome of Candida isolation from donor organ? And that's it. Thank you so much. And I will accept any question if there is any question.
Thank you, Rbab, for excellent review. Is there any question or comment?
Thanks very much. That was a very interesting overview. In regard to the lung patients, I have to say I'm not convinced that treating universally for a positive perioperative culture is is necessarily warranted. And I think that the idea of doing a follow-up bronch at 1 week is not necessarily practical. Like for the patients who remain intubated, certainly that's possible. A lot of patients are extubated, and so that might be a little bit challenging logistically. So it's clearly a big issue. Like there are patients who perioperatively, grow Candida and subsequently have significant infections. But I guess to my mind, it's not clear what approach is justified still, and I'm not sure that treating across the board is necessarily warranted.
Yeah, thank you. It is. This approach is not based on very well randomized controlled trial, or there is very paucity in studies done in this regard. So it is suggested by the American Society guidelines based on expert opinion. However, yeah, I agree. Maybe they propose this approach because you are doing usually the surveillance bronchoscopy. So it could be. It is not really associated with invasive fungal infection, but if invasive fungal infection happens, so it is associated with high mortality rate, like we saw in the empyema patient who developed empyema.
So the big issue we tend to have is with the pleural space infections down the road, and I think that what are the predictors of those is I think the key issue to us.
Yeah, I agree.
But thank you very much for the talk.
Thank you. Maybe also Dr. Shahid can answer this question, maybe because it is a debatable topic.
So I don't think, thank you, Rbab, very nice presentation. I don't think I have all the answers. And as you know, the data is being analyzed at this time. But what we found is that the rate of Candida infection, including invasive candidiasis, over a year was only 4.5%. And as Matthew said, that we do not institute universal prophylaxis. There are certain criteria that you alluded to in your presentation that we had agreed upon previously to institute prophylaxis in patients in whom we isolate Candida in the BAL. But and this is just a preliminary analysis, so word of caution that one of the things that is coming out to be two factors that is those, at least in the preliminary data of ours, which Tina is working on, has come out to be a significant risk factors with odd ratio of 10 is post or pre-op ECMO in lung transplant recipients and a requirement of renal replacement therapy. But stay tuned, we'll have better data soon. And I agree that doing a universal prophylaxis is not the answer. And the data I would point out to is from Baker's study, and that was from Duke. They used universal antifungal prophylaxis with inhaled amphotericin B, and their rate of invasive candidiasis is 11.5%. So, and they use inhaled lipid complex amphotericin B for 2 weeks for every lung transplant patients. So this is something to think about.
Thank you, Dr.
Hi, it's Dipali. I just wanted to comment on that, just our discussion about the lung transplant and Candida, preventing Candida, invasive Candida infections like pleural space infections. I'm thinking that maybe we shouldn't look at Candida in isolation and look at, the incidence of both Candida and Aspergillus together. And, maybe that, if that's high enough, as sort of a global sort of fungal infection incidence, then possibly universal prophylaxis is warranted rather than just looking at Candida separately and Aspergillus separately. I'm eagerly awaiting for the study that you're doing, Shahid, but I'm just thinking if we kind of look at both together rather than just looking at one thing, because the medications that we have prevent, many of them will prevent both Candida and Aspergillus.
Yeah, so I think this is a valid point, Dipali, and we have published our preemptive therapy data for invasive aspergillosis. And for all those patients, at least in this cohort of 700 plus lung transplant recipients, any patient who had Aspergillus positivity or galactomannan positivity has received antifungal prophylaxis, right? With an azole or any kind of candida. That's why we looked at what is the utility of isolated Candida in the BAL. And that's where the data, I think the picture will become much clearer once the data is analyzed.
Thank you so much. So I think the conclusion is universal prophylaxis is not recommended or even targeted prophylaxis for lung transplant recipients at this point. But of course, we will be having more data from patients who receive lung transplant at UHL and other centers. That will be definitely helpful to have a better answer. Any other comments or questions? Okay, thank you so much, everyone. And it was a great talk. Thank you, Rbab, and have a good day.
Thank you so much.
Thank
Have a
you,
nice day.
Rbab.
Thanks, Rbab.
Thanks, Rbab. Thank you.